I'm Adrian Butler with UT Health East Texas Orthopedic and Sports Medicine Institute. Here are the 5 things you need to know about ulnar neuropathy or cubital tunnel syndrome. Cubital tunnel syndrome is a condition that we see frequently in the office with numbness and tingling into the ring and little fingers. This is different than carpal tunnel syndrome, which typically has numbness and tingling in the thumb, index, and middle fingers. Symptoms are usually exacerbated or worsened with elbow flexion type of maneuvers. Patients will often complain of pain at night in their ring and little fingers, or sometimes their entire hand. Your physician will typically take a detailed clinical history of your presenting symptoms, which will often clue them into the condition. In addition, x-rays of your wrist and elbow will be obtained to rule out underlying conditions that may contribute to your symptomatology. Clinical examination will also be performed, focusing on the ulnar nerve at your elbow as the source of your symptoms, but also to rule out other conditions that may contribute to similar symptoms. Ulnar neuropathy is typically treated with home exercises for nerve glides and avoiding elbow flexion as much as possible. This is usually recommended at night, as most people sleep with their elbows in a flexed position. In addition, electrodiagnostic studies are helpful in evaluating the ulnar nerve and ruling out other conditions that may mimic symptoms of ulnar neuropathy or cubital tunnel syndrome. Patients who present with severe symptoms with constant numbness and tingling in the ring and little fingers or loss of hand function typically will need early surgical intervention. Patients who also fail conservative management for minor symptoms may also wish to pursue surgical intervention. Surgery for cubital tunnel syndrome is performed on an outpatient basis where patients come in for surgery and leave the same day. Typically, the incision is made over the inside of the elbow and the nerve is decompressed. In some individuals, the nerve may need to be moved from behind the elbow to the front of the elbow to prevent ulnar nerve irritation after decompression. For patients who undergo nerve transposition or movement of the nerve from behind the elbow to the front may need to be splinted briefly after surgery. In patients who do not require nerve transposition, typically recovery is a soft dressing and early range of motion. Most patients with minor symptoms will improve nerve recovery after about 2 to 4 weeks. However, in severe nerve compression, recovery may continue for up to a year and a half.